Hello friends, let us come to the next topic, that is the anatomy of external nose. Now we all know that nose is in the center of the face. So now this nose is very important for the beauty of face. For the face to look beautiful, it is very important that the nose should be of appropriate shape and size. Okay, only then can the face look beautiful. So how do we determine what is the appropriate shape and size of the nose? Okay, so for the shape you can all say that the nose should be in the midline, it should be straight, it should not be too broad, it should not be too narrow. But how do we determine that? Okay, why I am telling you this? Because a patient may come to you and patient may say that my nose, I think it is not looking beautiful and I want you to improve it. So as to improve it, you should know what are the dimensions that will look good on a particular face. Okay, so how do we determine the dimensions of the external nose? You see, the nose, it occupies the middle 1/3 of the face, right? So as you can see over here, it occupies the middle 1/3 of the face lengthwise. Widthwise, you can see that the nose, it occupies the middle 1/5 of the face, right? So nose is in the center, it is in the midline, it is straight, but along with that, lengthwise it is generally 1/3 and widthwise it is generally 1/5 of the face. Okay, so that is the front profile of the face. Suppose we look in the lateral profile. So you see, this is the lateral profile of the face, and now we see the nasal tip projection, okay, or the nasal height. Now what do I mean by nasal height? Let's look in this photograph. You see the deepest point over here on the nose, that's known as nasion. And then we have the tip defining point. In between them, what we have is known as nasal length. As we discussed, the nasal length is dependent upon the face. The nose is 1/3 of the face. It occupies the middle 1/3. Now, if we draw a line from the nasion to this alar facial groove, we'll get a plane, and that plane is known as vertical alar plane. So now what we can do is, we can draw a perpendicular line from the tip to this plane, and we will call it as the nasal height. Okay, so that is the nasal height. And this nasal height is also dependent upon the nasal length. And nasal depend in turn is dependent upon the face. How is that dependent? That is known as good ratio. Okay, so the good ratio is nasal height upon nasal length. All right, and an ideal good ratio for the nose to look beautiful is 0.55 to 0.6. That is an ideal good ratio, right? Okay, so this is how we determine the size of the nose. Now, what structures form the external nose? So the external nose, as you can see over here in this photograph, it is formed by both bone and cartilage. So as you see, the upper 1/3 is bony, whereas the lower 2/3 is cartilaginous. Now this upper 1/3, the bony part, this is formed by majorly the nasal bone, as you can see over here, but it is also contributed on the sides by the frontal process of maxilla. So you can see this is the maxillary bone, it goes up and forms the frontal process of maxilla that supports the nasal bone laterally, right? So this is the upper 1/3. Now what about the lower 2/3? The lower 2/3 is cartilaginous, and it is formed by 3 paired and 1 unpaired cartilage. Okay, so we have 3 paired cartilages and we have 1 unpaired cartilage. Let's look at these photographs. What do we see? Superiorly we see the nasal bones, right? So remember, anterior, the superior 1/3 is by nasal bone, supported on the lateral side by the nasal process, the frontal process of maxilla, right? The lower 2/3 is by the cartilages. So what do we have? Number one, we have the upper lateral cartilage. This is a paired cartilage, one on each side. So we can see the upper lateral cartilage. Below that, you can see the lower lateral cartilage, which is also known as alar cartilage. It contributes to the ala of the nose, right? And number three, we have on the sides lesser lateral, also known as lesser alar cartilage. So we also call it as lesser alar cartilage. So you see, these are the three paired cartilages, right? Now, in the center of these, we have the unpaired cartilage, which is known as septal cartilage, right? So as you can see over here, in the center, we have the septal cartilage. Okay, what else can you see in this diagram? You can also see the lower end of the alar cartilage, also known as lower lateral cartilage, right? So you can see this alar cartilage. Now this alar cartilage, if you see, it has two cruras or two crusts. Which are those two cruras? We have the lateral crura or lateral crust, and we have the medial crura or medial crust. As you can see, the lateral crura, it contributes to the nasal ala. So that is why it is known as alar cartilage. But notice clearly over here that majority of the ala is still fat. Although we have a alar cartilage which contributes to ala, but the majority of ala still consists of fat. That is why the nose piercing is done at ala. Why? Because the ala consists of fat. Okay, so majority of this part is fat. Remember, the body piercing is preferred at places which have only fat, such as the nasal ala. Okay, now the medial crust over here, you can see the medial crust of the two sides, it comes and meet in the midline, and together they form the crest of the nose, which is also known as columella. Okay, so they contribute to the columellar septum, right? This is formed by the columellar septum is formed by the two medial crusts of the lower lateral or the alar cartilage, right? Okay, now let's come to this diagram. What do we see in this diagram? We can see the paired nasal cartilages that we just discussed. Now, important point to note over here is that the upper lateral cartilage, you see, this is the upper lateral cartilage, right? Now, the lower end of this upper lateral cartilage, this over here, which I am now marking, it is being pressed internally or medially by this lower lateral cartilage, alar cartilage. So, alar cartilage is pushing the lower end of upper lateral cartilage. Okay, so the upper lateral cartilage, instead of being straight, it is going in like this. You see, it is going in like this. This part which has gone in, it forms a valve inside the nose, right? So there are two valves in the nose. One is the external nasal valve that is formed by the ala and the septum, right? It is at the nasal opening. And the second, the more important valve is the internal nasal valve. Okay, this internal nasal valve is formed by lower end of upper lateral cartilage. So that is on the one side. What will be on the other side? On the other side, we have the nasal septum, of course. On the other side, there will be nasal septum, right? So internal nasal valve is formed between the lower end of upper lateral cartilage and we have the nasal septum, right? So these are the two main structures. There is also a contribution by some part of the inferior turbinate, but these are the two important structures. Now, remember, in between them, let's look over here. in between the lower end of upper lateral cartilage and the septum. The minimum angle over here should be at least 10 to 15 degrees. Okay, if it is less than 10 to 15 degrees, it will cause nasal obstruction. Right? So this angle has to be more than 10 to 15 degrees. Right? Some undergraduate books have mentioned this value to be little higher. What I am talking about is the minimum value as per what is given in the Scott Brown textbook. Okay, so this is the minimum angle that should be there to prevent nasal obstruction. Right? Okay, now suppose there is a nasal obstruction and I say also remember that this internal nasal valve is responsible for approximately 50% of the nasal airway resistance. Okay, how much? 50% of the nasal airway resistance is because of the internal nasal valve. Right? Okay, so this is a very important part in the cross section of the nose because this is the part that will give the maximum resistance to the airflow. Okay, any obstruction at this place can quickly block the whole nasal cavity. Now remember, let's say there is a patient who comes to you with nasal obstruction and you suspect that this obstruction may be because of the internal nasal valve. How will you check that? Now to check that, we have a very simple test and that is known as Cottel's test. Okay, so what do we do in Cottel's test? In Cottel's test, what we do is you simply keep your fingers on the cheek of the patient. Right? So this is how you keep the fingers on the cheek of the patient and you pull these fingers laterally. Okay, so when you pull these fingers laterally, you pull the cheek laterally, and now what happens? This pull the external nose, okay, the cartilages are pulled, and if there is a obstruction because of the internal nasal wall collapse, the airway will open up. Okay, so you pull it laterally, pull the cheek laterally like this, and the airway opens up. That means the obstruction was because of internal nasal valve collapse. Okay, so this is an important question that is asked in the exam. Recently, this question was asked in the FMG December 2020 exam. Okay, so just remember this image in your mind. You are putting your fingers on the cheek and pulling it out. That is known as the Cottel's test, used for checking the internal nasal valve collapse. Let us now discuss the next topic, that is the disorders of external nose. Now let's start over here. What do you see in this man? When you notice this man, obviously you can see over here that his nose is deviated to one side. Okay, so what will we call this condition? We'll call it as deviated nose. Okay, so this is an external deformity. We will call it as deviated nose. Now many a time students, they will straight away answer it as deviated nasal septum, DNS. Now please remember, this condition is a deformity or a deviation of external architecture of nose. Now the septum may be deviated with this, or it may even be straight. We don't know that unless we do an internal examination of the nose, right? So we will not call it as deviated nasal septum. Rather, we will call it as deviated nose. All right, am I right? Okay, so this is a deviated nose. It's an external deviation, right? We will not call it as deviated nasal septum. Now what treatment will we offer? We'll offer a corrective surgery for this, and that is known as rhinoplasty. Okay, so the corrective surgery for this type of deviated nose is known as rhinoplasty. All right, so you can see over here, now the nose shape is corrected, it is straight, so that is known as rhinoplasty. Let's look at this photograph. Now what do we see in this photograph? We see in the first photograph over here, you can again see that the nose is deviated. The tip, however, is in the center. You see the nasion, the tip, they're in the center. The base and the tip are center. But the bridge is deviated to one side. So this is a C-shaped deformity, also known as crooked nose. Similarly also, here also you can see that there is a crooked nose. So this is a condition known as crooked nose. Treatment will once again be rhinoplasty, surgery of external nasal architecture, generally done to improve the shape of the nose, right? Okay, next is nasal hump. So what do you see over here? You see in the lateral profile that the nose has an extra protrusion upwards. So that's known as nasal hump. Now you see this nasal hump, if you see over here, is not just bony. It is bony and cartilage both bone and cartilage over here. You can see they are protruding upwards and causing this nasal hump, right? So what treatment will we do? Again, if you're doing a surgery of the external nasal architecture, it is known as rhinoplasty. But over here, we are reducing the size of the nose. So this is known as special rhinoplasty, also known as reduction rhinoplasty. So in this reduction rhinoplasty, we will cut the extra bone and cartilage. Okay, you see the tip is also little bent down. Because of this, the tip should be like this. So we can also take out a part of the lower lateral cartilage and we can lift up the tip, right? So that's known as reduction rhinoplasty. Okay, now the next condition over here, you can see that this girl has a severe saddle nose. So what has happened over here? The bridge of the nose has collapsed inside. Okay, so this is known as saddle nose. Now what will we do for this girl? We have to increase the height of this nose, right? So we have to augment it with some cartilage, some tissues. So that is known as augmentation rhinoplasty. Okay, generally we harvest a cartilage that can be a costal cartilage. It can also be harvested from the pinna. Okay, earlier bone such as iliac crest has also been used, but nowadays bone is not preferred because it gives an unnatural bony feel to the nose. We prefer cartilage such as from the costal cartilage or from the pinna, and we reconstruct the nose. So that is known as augmentation rhinoplasty. You can also use the cartilage from septum. If you're also doing septoplasty, for cartilage from septum may also be used, but generally in such a severe kinds of saddle nose, septal cartilage may not be enough. If there is a small amount of saddle nose, of course you can use the septal cartilage. Okay, right? So these are the different types of deviations of the external nasal architecture. Now let's look at this condition. What do you see? This condition is known as rhinophyma. You see over here, so this lobulated swelling, this is known as rhinophyma, also known as potato tumor. Now this rhinophyma or potato tumor is generally seen in males around 35 to 40-year age group. Okay, so middle age males, 35 to 40-year age group, we see this condition. Now what happens in these patients are generally long standing cases of acne rosacea. So these patients are long standing cases of acne rosacea. Now what happens in acne? In acne, the pilosebaceous duct gets blocked. So because the pilosebaceous duct is blocked, the sebaceous secretions, they are not able to come out. So because the sebaceous secretions are not able to come out, now they start accumulating inside the sebaceous glands, and because of that, the sebaceous gland increase in size, right? So what happens? There is a benign hypertrophy of sebaceous gland. Very important MCQ over here. This is a benign hypertrophy of sebaceous gland, and that leads to formation of a lobulated mass on the nose, right? Now what is the problem with the patient? Why will the patient come to you? You see, this mass is not causing any obstruction or any other problem other than cosmetic problem. So there is a problem of cosmesis. It looks bad, right? There is a cosmetic problem or problem of cosmesis. It looks bad and the patient will come to you for its treatment. Now, what treatment can you offer? Yes, see, many students give me the answer as excision. So please understand that this disease is on the skin of the nose. Okay, it is because of benign hypertrophy of sebaceous glands. If you want to excise it, that means you will have to excise the skin of the nose, and you have excise the skin of the nose. If you excise the tip, all this skin from the tip of the nose, the patient will have a bigger cosmetic problem. Okay, you cannot cut the nose and expect patient to be happy. So what will you do? You cannot excise this disease. It's not a tumor. The name may be over here tumor, but tumor is a growth in which there is hyperplasia. Okay, pathologically speaking, the cells have to multiply. Now, this over here, however, is a hypertrophy. There is no multiplication of cells, only there is increase in size of cells. So there is a hypertrophy, right? So the treatment what we will offer to this patient is we can do derma abrasion. Okay, so you see, whenever you fall down, sometimes you fall down, you have some abrasions. So what is an abrasion? Abrasion is an injury in which the outer layer, the epidermis is gone, but the lower layer, the dermis, is still preserved, and that leads to a scarless healing. Right? So now, similar to that, we will give controlled abrasions, so which are known as derma abrasion. Right? So you will shave off the part that is above this surface. Okay, above the skin surface. So we'll call it as derma abrasion, and nowadays we can do this derma abrasion with the help of carbon dioxide laser. It will give us better results, even finer margins and sharper margins. Okay, so scarring will be even less. So what we can do is we can do a carbon dioxide laser derma abrasion, and we can remove this cosmetic problem. Okay, so remember, treatment of choice for rhinophyma is not excision, it is carbon dioxide laser derma abrasion. Right? Let's go to the next condition. The next condition is rodent ulcer. Rodent ulcer is the other name for basal cell carcinoma. Okay, now this basal cell carcinoma or rodent ulcer, this is the most common malignancy of the skin. Most common malignancy. Okay, and this occurs mainly on the sun exposed areas of the skin. Why? That is because of exposure to ultraviolet B rays. Okay, and because of that, it is more common in white people. Why? Because the black people, the colored people, we have melanin pigment. The melanin pigment absorbs ultraviolet B rays. So we have less predisposition to rodent ulcer as compared to the white people. Okay, so white people, the Caucasians, they are more in danger of developing basal cell carcinoma. Now, where will it develop? The most common location is hand, the dorsum of hand, and the face, of course. Okay, because these are the most exposed to sunlight. So what on the face? We have the nose, we have the cheek, we have the pinna. So any of these places the rodent ulcer can develop. So it can develop on nose, right? Age group is generally 40 to 60 years. Male and female both have an equal incidence of developing basal cell carcinoma. Now, remember, this tumor is a locally invasive tumor. It invades and erodes the local area. The distant metastasis is rare. You see, the name rodent came from the phenomena that rather than spreading superficially, more will go inside. Okay, so the invasion into the tissue will be more than what is visible on the outside. So that is why it is known as rodent ulcer. Okay, now suppose a patient comes to you. How can the patient present? You see, in the different photograph, there are different varied types of presentations of rodent ulcer. It can present as a cyst, or it can present as a pearly nodule, okay, or it can present as a ulcer with rolled margins. So you can see over here, we can also have an ulcer with rolled margins. Now, as I said, this disease, this malignancy does not have distant metastasis. Most of the times, the distant metastasis is not there. So, the treatment is local. So, what do we do local? We'll do an excision. Okay, but locally it invades. So, what is visible to you outside, it may be more inside. So, the treatment of choice for this disease is wide local excision. So that means you take a margin of around 2 to 3 centimeter or as much as possible. So in case of nose, 2 to 3 centimeter margin of course is not possible. So we'll take a tissue of normal healthy tissue around it and we'll excise this tumor. Okay, so as you can see over here, this tumor has been excised, and so as to not only excise the tumor but also to give a good cosmetic result. So this is known as wide local excision, which is the treatment of choice for basal cell carcinoma or rodent ulcer.